So we have a super guest today, and I'm so delighted that you've taken time to be with us, whether you're listening and taking notes on the treadmill or driving to work. This is a keeper today. Our guest today is speaking to us from Queensland, Australia, which means that she's in a really remote area, and which means she's using Starlink. And so if we freeze up on you, it's not you, it's us. We're just switching satellites. Don't ask me how it works, it just does. And I am just delighted to welcome Dr. Sarah Smith from Australia with us today on our podcast.
Hi, thanks for having me.
Absolutely. Now, this not only is it a keeper because of our guest, but what we're going to dive into today is incredibly important. Uh, Dr. Smith is a world expert on effective charting. She is the host of the Sustainable Clinical Medicine podcast. I will let her just describe her pathway, what brings her to us today. She's literally practiced in both hemispheres. So, Dr. Smith, talk to us a bit about your pathway that has us talking together today.
Thank you so much for the introduction. So I'm a family physician, trained rural, and did all of that training in Australia. And at some point in the early career, we decided we wanted to hop continents and went to Canada to see something different for a year, and ended up there for 12 years. So this was
Where
after
in
travel.
Canada were you?
In Alberta, so right between Edmonton and Jasper, little country town where I did emergency medicine and family practice. I'm the sole income earner for my family. And there's a little bit of a deep, dark, horrible side of medicine, which is this paperwork problem and the administrative burden. And it followed me from Australia to Canada. Through two different healthcare systems, through multiple electronic medical records. I would see patients. And then at the end of the day, the work was not done. There was then still the inbox work, the charting, and a small family to come home to. And weekends of work, evenings, lost sleep, and really just feeling quite miserable about it. And this was about 15 years into working in family medicine. And I wondered, is this sustainable? I feel like I need to leave medicine, but I've got no other skill set and I've got a family relying on me for money. Now what? And I really didn't have any answers. I'd asked every mentor along the way and they didn't have answers other than coming in on Sunday. So I hadn't got very far with asking my colleagues, friends, and mentors. It wasn't until I was on my way to a teaching event where I was going to be teaching students that I actually decided I better be a better motivational speaker. So I might pull it on a podcast and listen to some sort of motivational speaker, which happened to be a life coach who happened to blow my brain a little bit in terms of a shift in the way impossible could become possible. So over the course of 18 months, I really desired different. And I didn't believe that it was possible at all to begin with. But I made little shifts until I had got myself to the place of I could see patients, I could go home on time with everything done. And that created an amazing bucket load of time for myself. And then I thought, well, you know what? I'm going to have to go teach my friends how to do this too. And so over the course of the last 5 years, that's what I've done is taught over 1,500 physicians in my program alone and others within other teaching events. Um, many physicians and nurse practitioners and clinicians this same skill set. So that is where we're at now. That's why we're chatting.
Marvelous. And so, to our listeners, some of you may be in a position where you don't chart, but when we have an expert with us that's done this with literally hundreds of physicians, this may be a podcast that you want to pass along to others because I don't know of a physician when that doesn't cringe when she sees system upgrade this weekend that just and I had this doctor a couple of months back where there I don't know if it was Cerner or Epic, but one of the two big ones they did a system upgrade and it wiped out all of their templates.
Mm,
And so, the classic oxymoron, as one physician told me, is system upgrade because it
mm,
just it wipes everything out. So in our pre-call, Dr. Smith and I ran over a couple of scenarios. And to kick us off, I'm going to true story changed for confidentiality. Working with a cardiologist who is seeing 25 to 30 patients a day. I'm coaching him on some various items and I'm just getting to know his world a little bit better. And he tells me that he's seeing this number. And so I'm figuring out in my head how that fits into a 8 a.m. start, 4 p.m., 5 p.m. finish. And I'm thinking, okay, that's somewhat manageable. It's close to being pretty tight. And then he hits me. I literally, doctor, can close my eyes and remember where I'm sitting, where he's sitting, what I'm looking out the window at. He said, Carl, you have to remember that for every one of those patients, I have at least 10 minutes of charting to do. And so I did some fast math going high. 10 times 30 is 300, divided by 60 is 5 hours. And so I said, and one of his problems, he was always in email jail or coaching, the backlog was horrible.
mm,
And I thought, oh my goodness, he gets home, has dinner with his family at 6, and gets to look forward to 11 o'clock as his start time.
mm,
So that's my first scenario. And
mm.
you enlighten me that it's even more than that. So dig into that isn't just 5 hours, and I'll turn that to you.
Yeah. So hi to all our cardiologists out there. And you'll find family physicians, general medicine, endocrinologists, nephrologists, they're all in a similar boat. So we have, for whatever reason, our appointment books are set up the way they are. So you might have some differences between new patients and returning patients, but you'll often have this high volume of patient number coming through in the day. And if it was just the patients and the charting, you're right, it potentially could be manageable, but that is not the truth of the day. That is the patient protected time where we're seeing patients and closing charts. But then there's everything else. So for our cardiologist friend, he is most likely also his expert hat would include reporting on the echoes, reporting on the stress tests, having some other form of role where he's got other work lists to account for as well as the in basket. So that's all of the messages coming in from his staff, all of the results coming in. And so now we're getting exponentially increasing amounts of work. And then let's just throw in there the direct patient to doctor messages, which can be overwhelming. So we've already got a very, very stressed and overwhelmed doctor. And then we're going to look at what else are they putting onto their plate? What else is in that mountain before they can go home? And if they're anything like me, they have this similar experience of, am I ever done? I just sit and look at it. What's wrong with me? And that's the last question I want you asking yourself because it's not what's wrong with you. We know that this is not a sustainable system in the way it's being done right now. So if we were talking, I was actually talking to a cardiologist just last week about this exact scenario, and we're working on really how are we going to do this? If your goal is, I want to leave the office, if his last patient's at 4, maybe he decides that he wants to do a little bit of something before he goes home, but he wants to be out the door at 4:30 or 5 with everything done. Now, from where he is right now to there, that is a massive void. That is completely impossible. And how on earth are we ever going to solve for that? Okay. And so it starts with, what do you want? And so for my personal sentence was, I don't want to do this later. I'm done with later. I want to be home with my kids. I want my weekends back. I want to make time for rest. I want this to be sustainable. I'm done with later. And so throughout the day, my rolling thought initially was, I don't have time for that. I don't have time for that. I'll do that later. I'll do that later. I'll do that later. And you can just see the little quits on myself that created a 5 p.m. disaster. By 5 p.m., I was exhausted, overwhelmed, dreading it, frustrated, angry, miserable. And I was getting texts saying, when are you going to be home? Right? It's not a pleasant place to be. I get that. I get that. So we now need to step into, well, is it possible to have a different experience of clinical medicine right now with nothing changes, same number of patients, same EMR, same MAs, same staff? Now what? What is it going to look like to try and get across that void? And even if we don't get fully there, even if something, little tiny things start to get better, it can make a huge shift in energy in the day.
Absolutely.
Yeah, so it starts back inside you. So if you're the one with the desire to make changes, that's the best place to start because you can control you. You can't control your others. Though, if you've got people working within your medical team, we absolutely know there are ways we can start to have conversations with our staff. We can start to look at what's in my inbox and what is not physician work and what should be immediately removed by teaching others how to do this on my behalf. And what does stay in my inbox and why, and how can I get it out again as fast as possible?
Absolutely.
We're going to
So,
look at clinical day from every angle to figure this out, figure this
X.
puzzle.
So, second scenario, working with a family practice doctor here in the Northwest, and she was talking about not charting, but it's a perfect example because you talked earlier about the errors in math
Yes, the math error.
that people aren't accounting for that could easily lead to the frustration you're talking about. So here's
Mhm,
the scenario. Um, she's in a very busy clinic, um, family practice, as I mentioned, and she has 15-minute appointments or 30.
mhm,
Most of them are 15. 30
mhm.
apparently is for new patients
Yeah.
or an extended problem. I'm not sure. But her comment to me that you commented on was, Carl, it takes my MA, of the 15 minutes I have, my MA takes 7 to room. That leaves me 7 minutes to do my clinical intervention. Um, and you immediately came back and said, she doesn't have 7.
She doesn't know seven.
So walk us through, and we have listeners right now saying, Carl, I thought my sessions were confidential because you just described my world, and I didn't because I wouldn't have. But
But this is common. You will hear this over and over. You'll have people yelling at the podcast, that's exactly right. They take 5 minutes to prove my patients. Okay. So this is widely common. Okay, widely common. So the 15-minute appointment, even that, we'd love to say why, right? Why? Why is it 15 minutes? But of course, this is the reality you exist right now, and your appointment book's probably full for the next 3 months. So this is your reality for at least the next 12 weeks. And so now what? Okay. So that MA is going into the room. Why are they going in at the start of your appointment time? So if 10:30 appointment and you happen to be having a great day and you're ready at 10:30, but your MA is still in that room, just a little question to your brain, why? And what are they doing in there? And what they're doing in there, what is helpful to me? Has anyone asked them what priorities you're interested in for what they're doing on your behalf? And why aren't you in there too? Okay, so you have choice always. So having conversations not at 10:30 in the heat of the moment when you're frustrated, that's not cool from the point of view of being a good leader. But just sitting with an MA. So our MAs have come from different levels of experience. Some are very good. They're strategists. They'll be a step ahead of you. They'll have your next patient roomed and they'll be dealing with the patient you just saw or the next patient past them. Okay, so that's a nicely set up working team that's collaborative. So some of them are strategists and they might figure that out on their own. Others are technicians. They will follow a tick box and they can't think for themselves in terms of the priorities. They have no idea what you need. So if you're going in there saying, well, all that history they just took is of no value to me, I'll start again, then that was not good use of their time or yours. But the vitals might be great, or the might not be being done right either, or maybe they didn't set up the room the way you needed it set up. So conversations matter. So you could say, hey, if it's 10:30 and the patient appointment's at 10:30 and you're in the room, I'm going to come in. Nothing's gone wrong. I'm just going to get started because I've got 15 minutes and we want to keep the flow going. We all want to get to lunch on time. How do we empower those people to be successful for you on your behalf, for your patients and their quality of care? What is it that you need them to concentrate on first?
So I'm going to add another twist to the story that will, I hope, doesn't rile too many of the administrative personnel that are listening. But I have heard more than I care to count. Carl, I brought this up, but I was told that I need to stay in my clinical lane, and this is by the infamous clinic manager, who basically says, Dr. Smith, in somewhat a patronizing way, Dr. Smith, those are our organizational norms. And
Hmm.
basically, you take care of the patient, and we'll take care of how you take care of the patient. And it's enough to drive my poor clients up a wall. So when you have that very well intended, but perhaps, um, oh boy, am I stepping in it now? Somewhat misguided in regards to how the front line is feeling. How do you deal with the office manager that says, Dr. Smith, you stay in your lane and let me run my clinic?
Yeah.
Any suggestions there?
It's about forming relationship with your immediate staff. So your little team need to work collaboratively together. So finding out about the person that you're working with, what they value, how they're working and why, and just asking good questions and staying in that space of valuing them, but helping them together have a commonality of goals. So this is how teams work well together. When we know we're doing things for a purpose, it's easier to meet those expectations and be successful. So praise where praise due doesn't go astray. Understanding who they are, where they live, what other things are happening in their lives, what stresses are. This is part of good leadership and good team forming, is that microcosm of who is in my direct team today and how can we work well together. Then there's bigger issues like how many steps do we have to walk to get to the printer? How many steps do we have to walk to get the equipment that we're going to need today? All of that matters. There'll be stresses on your MAs that you're not necessarily seeing until you have these discussions.
Mhm. So you said something that I also hear a lot about, and I want your view on it. Um, I don't, again, lots of examples in my career of when I talk to physicians about leadership. What I hear is no one reports to me, I'm a worker bee. I don't know what you're talking about leadership. I'm not on an org chart except at the bottom. And yet in our pre-call, you really push back on that no, physicians are leaders. Can you dive into that?
Yeah. So if you're really not going to have conversations with your team and you're just going to walk in once the MA is ready, you're going to have consequences. It's going to have a knock-on effect for your whole day. These are compounding minutes. You're already pushed if you're trying to see a patient in what you think is 15 minutes, which is actually 10 because you've got charting to do. And then the MA takes 3 to 4 of them, or 5 of them, or 6 of them because we've not had those conversations. Then there's a knock-on effect. So you've got compounding minutes behind, and now you're 40 minutes behind. And so now you're leaving that charting because, oh my gosh, I'm running behind and I can't possibly stop and do that now. Now what? Now you're adding suffering to your evening. Now
Mhm.
you're adding suffering to your weekend. And so starting with our role as a team, even if you don't want to call yourself a leader, you're a team member.
Mhm.
That makes a huge difference to how our day can start to be different.
And all of these changing perspectives gets us into another topic we talked about. Um, some generations have called it the paradigm shift. Right now, our more common phrase is change in mindset.
Mhm.
And like we like we were chuckling about, for every attempt at changing a mindset, there is a very well-formed habit screaming its head off that this is a bad idea because
Yeah.
the habit is accustomed to the comfort zone. And this mindset shift that Dr. Sarah Smith, half a world away, is suggesting is what? So, can you dig in a bit on, and that this may tie into your possible impossible example of earlier, walk us through what it takes to start thinking about something differently, especially how you run your clinical day?
Hmm. Yeah. So when I first heard that impossible things were possible, like I said, listening to this general life coach, I'm like, but you don't understand. But you don't understand the pressures. You don't understand this administrative burden and paperwork. It's such a big problem. It's like literally impossible. Like it's not impossible things are possible. This is impossible. Right? Like impossible, like literally unable to be changed. But then hearing the her talking about splitting up the things. So we've got the concrete things about your day, the EMR you work with, the team you work with, the number of patients you see in a day, half of them need an interpreter, all the things. Okay. And my charting takes 15 minutes per patient. So they're kind of the current facts of your day. And then there's the story we're telling ourselves about the day. And sometimes it can start just by noticing what you're saying about your day. And my story was not pretty. This sucks. Why do I have to do this? I hate this. I'm running behind again. I can't believe they want me to now mark this box to say if somebody's a smoker or not. Stop asking me to do things. Don't you realize how busy I am already? Okay, this was my lived experience of my clinical day. And so the steps of, well, I want something different and nothing gets to change because I've got literally nowhere else I can work in town. Like this is the only medical practice in town. My whole family's moved across the globe. I'm the only income earner. I literally am stuck, which is also a story because we have choice. So even learning that, I have choice. There's infinite possibilities. Even a tiny, tiny change can make a huge difference.
Can you give an example of that? Of a
Yes.
tiny change making a big difference?
Yes. Pocket snacks. Okay. If you don't have time to go heat up your lunch, pocket snacks, honestly. You need to nourish your body. You need to have hydration. Our executive function is finite. We will run out and you'll have fatigue and decision fatigue, and your brain is tired, and we need to look after it. So, how can I make this a more human, loved experience for myself? How can I learn to exhale before I walk into the next room? Because I would get so frustrated that I'd sit and scroll for a few minutes before I'd go into the next room. What was that doing? Adding minutes and then adding more to my afternoon because I was dreading it so much. I don't want to put somebody else in my brain today. I don't want to do anything else. So learning to and then reminding myself, we can see the next one patient and walking into the room. And even noticing, what can I like about this interaction? Where did I laugh today? What was fun about today? It just counteracted the I hate this story. Just that little teeny tiny shift of I have choice. Well, where's my choice today? Well, I could choose at 12:30 instead of staying in the lunchroom for an extra 5 minutes to scroll. I could choose to go and sit in front of my computer, deep breath, and do a couple of things in my inbox so there's a bit less to do this afternoon. Like these can be those little teeny tiny changes. I could choose to walk out of the clinic and look at the sky for 5 minutes at lunchtime. That's a cool thing to do. Gives us a bit of horizon, a bit of fresh air, a bit of a shift. I'm doing this for me. This is a choice.
So, one of the things that I hear from many of my clients about burnout is that they, as one of my clients said, if I hear one more person suggest that I take the organizational yoga class, I'm going to go ballistic.
Yeah. Yeah.
Because it's kind of, well, little provider here, you just go do your yoga class and you'll still have to come back to a bazillion notes that you still haven't done, but at least you'll have a yoga class under your belt. And yet here I'm hearing someone on the very front lines in one of the most burdensome specialties saying that taking a deep breath, having some food in the system, going outside and looking at the horizon. How did you convince yourself that these weren't just little placebos, but were really, as I'm aware, biochemical changes that change the perspective? How did you get the this sucks, Dr. Smith, to no, you can control this? Because I know that there's going to be some pushback that you just don't understand, yet you do.
Yeah. There's science. There is science that is showing that the more emotional you are, the harder it is to think. So as we're exhaling and we're actually taking a moment to settle in, so we walk in the room, we sit down, we exhale, we put our feet on the floor, and we just listen for 5 seconds before we like do anything else. That is just you calming down. It's like, no, there's somebody talking at me. I better pay attention. But this is part of that. I care for my physiology. It's going to help my brain work a little better. The offloading. So one of the very first steps we start with is see the patient close the chart, which it sounds like the most impossible statement I could have ever made, especially to your cardiologist friend who's spending 15 minutes after the fact doing the note. How on earth could I do that in real time without extending my day by 4 hours? But the thing is, if you are not getting your documentation done in real time, then you are in a false economy. You are under earning. You've earned that money in the room. Now you're working a second job for nothing. Because very few doctors in the world get paid for their administrative charting time separate from the patient encounter. So for most of the people listening, they're earning their money while they're with the patient, and anything they're doing later is under earning. That's how they end up working for less than a hairdresser or other lower cost employment, is because they're spreading out this earning. And so when we're talking about see the patient close the chart, that is a massive shift in how we're going to do things.
Mhm.
That creates well, that's impossible. Now what? If you don't want to do it later. And so it's tiny, teeny, tiny steps of that. But as we do that, as you can learn to do this, think about going into the room, seeing patient number 6, and all the documentation is done, and you're seeing patient number 6. That encounter is so different because your brain is unburdened of all the mental aspects, the mental load, that working memory of keeping those last 6 in your head. And
Yeah.
we teach use any tool that helps. Templates, if they're not disappeared on you with the next upgrade, they take a while to set up. That's very frustrating for that human. I get it. Any tool that helps you. But it's also how am I doing this? What's in my note and why? What else is in my note? Why does it take 15 minutes and not 12, not 10, not 8? How could I do this in 6 minutes if I wanted to? These are great questions to start to ask our brain. And don't answer with, I don't know. Just be like, how could I make this 6 minutes, not 15?
Yeah,
What
absolutely.
else could I put into this chart now so I don't have to put it in later?
Mhm.
It's just that little curiosity of if I wanted different, what would I want to do first? What are the little teeny tiny steps? Because we're adult learners. We're going to make mistakes. We're supposed to. If our listeners were to decide I'm going to go to work tomorrow and I'm going to see patients and close charts, just like Dr. Sarah Smith told me to, by 10:30 they'd be exhausted. They'd be 40 minutes behind it. They would say, this sucks and I'm not doing it this way ever again. And they'll put it down and say that was a stupid idea. Okay, why? Because it's so different to how they've been doing it. That is a massive level of discomfort that they're throwing themselves in. But if you said to me, I'm going to go run 100 kilometers tomorrow, and you failed at kilometer 1, you would make no big deal about it because you'd be like, well, of course I can't run 100 kilometers on day 1. And you'd have to be signing up to fail for maybe, I don't know how long it would take to learn how to run 100 kilometers, but a long time, right? I have to go and fail at least 365 days. And maybe on the 366th day, I can do it. So, this is how we make changes as adults. Now, we can sit on the couch and we can say, I wish I was an astronaut, and it costs us nothing and we will never become one. But if you said, I'm going to do what it takes to become an astronaut, you are signing up for a world of pain because you have to do everything in your life differently than how you're doing it right now. And you have to expect that it's going to take a number of fails and a lot of discomfort to do things differently. So it's energy taxing. Anything we do about our day that's different to how we're doing it right now is energy taxing. So we love pleasure, right? Anything that's fun, like seeing the next patient is fun. We hate pain. Charting is very painful for our listeners. They have a story about it. It takes me 4 hours. It's eating up my weekends. I'm never done, right? So we don't like doing it. So we'll put it off till later. And we do things efficiently, even if it's not good for us. If it's something we do every day, we keep doing it every day because that's how our human brain is designed. It's designed to do things efficiently. So if we want to start doing things in a different way, I have to think about it. I have to turn up and do it differently. It's not the fun part. I have to delay my pleasure by sitting and doing this note right now before I see the next patient. But then my 5 p.m. self gets the benefit of that. Oh, look, there's one less chart today to do than there was yesterday. Yes, that's a win.
Okay. So one thing that I want you to dig in just a little bit more on that I think is huge, retelling the story. That part of this sucks, this is bad, I hate this, and the emotions that those words bring up.
Mm.
How does Carl the doctor, and I am not the doctor, this is hypothetical. How does Carl the doctor, because that example you gave of the 100-kilometer race is superb. Um, and we're such creatures of habit. One or two suggestions for Carl the doctor on changing that habit that
Mm.
you can dig in a little. You've given some great examples, but I know I have some listeners that are saying, yeah, but not so much.
Okay, so you'll hear yourself in your story and just know that all the stories are optional. So we can have every story we want to have about our clinical day. We can decide I love doing medicine. We can decide I hate doing medicine. It's a story. It's not a fact. The things we're saying about our day is well practiced. That's why we believe it, is because we'll say medicine sucks, medicine is unsustainable, because we have repeated that to ourselves over and over and over. So just know that the stories, the sentences about our lives are the changeable part. We can desire or choose any sentence. All the sentences are optional. So you can decide that I am going to see what else I could achieve about my day. I'm going to see if I can get these 10 things, these 10 urgent things in my inbox done faster. Or I had one challenge to myself one day. A script took me 5 clicks and 3.5 minutes. And I said, how else can I do this? That would be faster. And just sitting and being curious with, can I get these scripts out of my life faster? And the simplest way to do it was I printed the requests, because the toggling between screens cost me so much time, and what was the dose and which pharmacy was it going to. By having it just there in front of me, I was able to go click, 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 click. It was just so much faster. Like, yes, one thing out of my inbox faster. And so it's just the noticing of, how can I do this in a simpler or easier way? How can I make this easy on me? How can I defer this thing? How can I ask a team member to do this on my behalf? It's the being curious or asking better questions about our day. And then just the noticing. I notice that I'm dragging my feet and I'm hating on this. What else is possible? What is good about my day?
So as we wrap up here, I want to ask two questions. What haven't we mentioned today that you're thinking these listeners need to know this? Anything we've missed?
Okay, so we have not discussed that the system is broken.
Mhm.
So I don't want people thinking that it is okay that we have 15 minutes with patients and 300 things in our inbox. Of course, that is not kind to you, and you'll always be asked to do more. So the paying attention to, I need to look after myself within this system too. I look after my patients and I do a great job, but at the cost of myself in the way I'm doing it right now. How can I interact with this system in a way that looks after me too, that creates sustainability for me and rest and recovery time? Because rest is not optional, you guys. You need to rest. And so we, of course, we have wonderful people in the world working on the systems. And hopefully you are experiencing that where you are right now. But for many of you, things are happening to you and no one else will protect your time. That is your job, is to learn the ways to help you protect your time and to interface with this system in a way that looks after you too.
So, how do people get a hold of Sarah Smith, the charting coach?
Yeah, they go to chartingcoach.ca and they'll find all the things about me. The podcast, like you mentioned, is Sustainable Clinical Medicine Podcast.
So, for our listeners, I don't want this to go into the land of rhetoric and theory. I speak with enough of you to know how much this is weighing you down. And so you've just listened to a half an hour with literally probably one of the world experts on this topic. What I like also about Dr. Smith is she hasn't left medicine. She will probably get up from this podcast and go see a full clinical day. And so that front line, and having worked with so many hundreds of physicians, listeners, don't shortchange yourself. I would really suggest that one of the first things you do when you get in front of a computer is, again, we'll put it in the show notes, but it's thechartingcoach.ca, correct?
Yeah, just chartingcoach.ca. Yeah.
Dr. Smith, thank you so much for being with us today.
Yeah, you're welcome.